Hi, welcome all. Just waiting a little in the lobby, waiting for participants like always. I think we're going to give it a minute or two just to ensure that everyone in the lobby is actually there. I have smiles here, so everyone is excited. Not only you, but my colleagues are too. Waiting a little more. Still locking people in. And welcome. Welcome to today's webinar, which is going to cover the topic of unlocking new potential within the parallel workflow within sectioning. My name is Emily Unig, and you might have seen me for previous webinars. I'm the application manager here in AXLab, and within the next 1.5 hours, we're going to dive into field-focused experience on what we call the parallel workflow. The parallel workflow is innovations we all know today, the AS410M, but also the new kid on the block, which is going to be the AT192M. We're going to dive into how parallel workflow has enhanced laboratories out there, how it has improved results when it comes to patient safety, turnaround time, and relieving staff for repetitive tasks. So what we will be doing today is we are going to have an agenda. So I'm going to do a brief presentation of the two devices. You probably already know the AS, but the AT is for many a new kid on the block. Then I'm really delighted to have Zahrah Rosun and Paolo Ho from Cambridge. They're going to talk about their first experience with the AT and how to implement it. And then I'm also really delighted to have Nadia Nielsen from Odense to give her point of view on carrying on automation in the way that Odense has been doing for a long time. And then we're going to finalize it all with a Q&A session. And as you know from previous results, you can be stating your questions in two ways. In the top bar, there is a Q&A session, and there is also a chat. So you're more than welcome to choose either of them. Just note it has to be written questions you're stating. So I would now like to welcome my colleague Mette. She is known for her steady hand, laugh, but she will be my camera guy, lady, for this next little session. So when we are talking about the AT192M, we are referring to a capacity on 192 blocks. There is divided on 8 trays. The trays look like this, and you have your ordering of your blocks. This unit is compatible with any embedding device there is on the market. So it could be a Sakura block, it could be Synergy, or it could be the manual approach as we know it today. How we are controlling the trimming is we have up to 8 different protocols, and each protocol is divided into 3 steps. We have a roughing, phasing, and a polish. So we are actually taking the knowledge from a manual trimming, and then we are executing here on this table. So we start rough and going smoother, finalizing the surface for our sectioning. You can see that I can customize and tailor how I want my trays to look like, depending on, of course, the mold size and the tissue form. And we can control the thickness, the count, and the speed. In this case, you can see we have a performance under 1 minute, which is the typical average what we are seeing. The journey of the block inside this device, steady hand Mette, she's going to move a little, is that blocks are being taken with the sample truck arm from the trays, utilizing the barcode, and then it's going to be placed in the sample holder here. Then it's going to undergo alignment. There are alignment pins for the tilt and the height. And then there is a vacuum system here taking care of debris. From every stroke that the unit will do when it starts the trimming phase, it will be captured. So there is a camera taking care of all the images. So from every stroke, there is being conducted an image. In the running log, for instance, you can see how that sequence could look like. So this is just the block we had a few days ago. And what you can see here is I can actually, from my input and all the way to my output, I have my trimming sequence. And these sequences can be kept if you like, but it can also be used as a comparison to the before and after my trimming for a control, quality control. So that is the basic behind this system. And this system is rooted and created based on having the other device we're having over here. So I'm taking my tray because the units are compatible with each other. So I'm taking my trays from this device onto the AS. And now I can easily, with ease, load my full-faced blocks on the tray here. And what will happen is that the tray will go into the system here, will be placed here. The sample truck here again will capture the block, placing it here, utilize the barcode where we usually are dragging any information we need to conduct the sections. Then the block will be placed here in the block holder, undergo tilt in terms of height, tilt, temperature measure. We have a vacuum system. This is quite smaller than the AS, for why we are also using the 8D. And then it will start to do its sections. And when it starts to do the sections, we will have pre-sections going on to the carrier tape, and it will follow up here, and the section that needs to go on the tape section will also come up here, and then it will push out a slide. The good thing about the carrier tape, I can say, is that with this instrument, you will have minimized cross-contamination, because this tape measure will only handle one patient at a time. So we don't have that intervention of having floaters or anything that could cause cross-contamination. So slide will be pushed out. There will be applied some water on the slide by what we call purified water bottle. And this is actually going to react as your water bath. So droplets are merging onto the slide. Then we're going to have a print. This is very important because we want traceability. And then we go back. This section is now being adhered to the slide, and then it goes back for the QC, extension, validation of the barcode, so we don't have any cross-mixing IDs. And what will happen finally is that we can take out uniform sections that could potentially looks like this. So what you have is you have really steady placement and really steady thickness, which is sometimes what we are seeing the most struggle with. And this is thankful to the environment inside the system. So these two units are actually feeding into what we know today as the parallel workflow when it comes to sectioning. They can be standalone solution, or they can also work in combination. In combination is what we have been seeing giving the vast majority of benefits. And I'm really proud to give the words to our first speaker, which is going to be Zahrah Rosun from Cambridge. And she's going to take us through, from a lab manager perspective, how it is to purchase and invest in what we are associated with the parallel workflow when it comes to sectioning. So welcome to you, Zahrah. Can you hear me?
Yes, I can hear you. Thank you, Emilia.
Hey.
Okay. Right, so I'm going to share my screen. Can I confirm you can all see it clearly?
Yes.
Yeah, perfect. Thank you. Right, so thank you everyone for giving us this opportunity to discuss about what we're doing at Cambridge University Hospital. So I'm Zahrah Rosun, Histopathology Laboratory Manager, and we've been working on this automation journey for a few years now in collaboration with AXLab. So my introduction is just going to be going through why we have decided to go down the automation route, some of the process that we've had to follow in the UK, and then I will hand over to my colleague Paolo, who will give you more information in terms of the detail of how we are optimizing the 8192. We looked at the strategic need of the histopathology laboratory. At the moment in the UK, there is a requirement to meet 98% turnaround time within 10 days for all sample type. In order for us to do that, we've had to look at, what exactly do we need to be able to meet this turnaround time. So in the past few years, we've seen a significant increase in workload, which continues to be increasing, especially post the pandemic. A lot of it is in regards to block due to the increased complexity of cases, which then is increasing the amount of blocks and SLA that is being produced. There's also an increase in terms of patients being seen as well. In addition to that, we've been seeing that we do have a staff and skill shortages, which again is been a scenario across several labs across the UK. My graph here is showing you in terms of how many staff I currently have, and based on our capacity modeling, how many we need to have. But despite several recruitment, we are struggling to recruit staff. The other element then brings into the processes. At the moment, as you would know, histopathology has been the way it is for several years. We are currently at a point in time where there's been a lot of focus in terms of histopathology. There's more funding in terms of the automation being made available. And compared to a biochemistry lab, which is mostly automated, histopathology currently are the same. What we've then looked at is, okay, we need a different strategy in order to be able to manage the workload, mitigate the staff shortages, and also trying to work towards the 98% within 10 days turnaround time. A lot of this led us to look at, okay, what else is out there in order for us to be able to automate that, but as well as improving efficiency and also retaining staff skills. Our main focus has been always about improving patient care. So what can we do in terms of the newer technology, in terms of service improvement that we can implement in order to get to that? We're also looking at how do we support our staff and how do we build for the future. And the way the service is growing is leading towards digital pathology, AI, genomics. And in order to be able to focus on the growth as well, we've looked at our automation pathway. So essentially what we're working towards is looking at the different processes. What part of the process can be automated? What part of the process can be manual? The manual process then highlights your staffing needs in terms of specialty work, any manual work that can't be done by automation. But then it automates a lot of the routine work, which is quite repetitive, but also requires a lot of time that then the automation helps us to alleviate workload pressures from the lab. And it also helps looking at how can we improve staff well-being, especially histopathology being such a manual, repetitive process. We are more keen towards getting ORSI injuries and so forth. We kind of started looking at our workflow. So of course, digital pathology, this was something that we already had. We're starting in that was the back of the process because it's more standardized. So your slides are standardized, your blocks are standardized. So this is where we started from. The first thing that we looked at in terms of microtomy was the AS410, which was a success in our laboratory. Currently, we have two AS410s, and we are cutting about 40% of our blocks within that. The next natural consequence of that was for us to looking at the auto trimmer. Currently, we had people who were manually trimming the blocks, but in order to help improve that workflow, we invested in terms of the AT192. Some of the funding was done internally through us putting business cases through, as well as receiving funding from NHS England. Our key message in terms of automating histopathology was, as the work is growing and the current workload, there isn't enough staffing resource to be able to mitigate this increase of the workload. So we are trying to work towards an alternative solution in order to be able to manage current workload, but also the automation to future-proof any future complexity of work, any future increase in workload as well. And also we're working towards how do we improve the flow of the lab. So the current process manually, naturally, there's a lot of batching in histopathology. A lot of the automation helps reduce the batching and allows more continuous flow, which then naturally helps towards improving your performance in the laboratory and eventually your overall turnaround time. So at the moment we are optimizing the AT190, which Paolo is going to discuss in a few moments. And the aim is then to work towards pretty much automating a large portion of our work from the block microtomy. Then the staining digital pathology is already in place currently. I'm going to hand over now to Paolo, if that's okay. And then if you have any questions at the end, I will welcome any. Thank you.
Thank you, Zahrah. That was really enlightening for us. I think that we all know that labs are suffering with staff and we're suffering with a larger intake of samples. So that has to meet together. So looking into automation is, of course, one of the things that is really in the future. So we are still staying in Cambridge, and I'm going to give the next word to Paolo Ho. I have the pleasure of meeting him a few months ago, and you are having a different take on how it is to validate instruments like the AT. So welcome to you.
Thank you.
I will give you this.
Cheers. Thank you, Zahrah. Thank you, Emily, for presentation. And I'm Paolo, one of the trainee clinical scientists in Cambridge University Hospital, and I'm currently validating the AT192 at the moment. So I have divided the validation process into different phases, where phase 1 would be to determine the average trim depth for each mold type. And then phase 2 would be to refine the trimming protocols according to the tissue types and the mold specifications. And then phase 3 would be the comparative analysis, which is a systematic comparison between the auto trimmer and also manual trimming. And throughout these phases, we are using reserved tissues from patient samples before we moved on to any diagnostic tissues. So the rationale behind this would be to be compliant with the international standards, ISO 15189, to have this kind of solid evidence-based approach to the validation process. And even once we are happy with the protocol and the trim depth, we still will be monitoring the kind of diagnostic samples onto the auto trimmer to ensure that it's performing. So selecting the appropriate protocol for tissue processing. So I would say this is one of our biggest challenge in Cambridge. So when we first kind of got a machine, we didn't know where to start. So we kind of just started with grouping them with the specialisms. However, think about it, like if we group by specialisms, for instance, during sampling, the consultants would sample a uterus, for instance, then there would be multiple different types of tissue being sampled, from fallopian tubes to the cervix to the endomyometrium. So each of those tissue would have different kind of tissue depth to it. So by grouping them into specialism with one trimming protocol for each would be quite difficult. Therefore, like with XLab support, we have decided to group them into like mold sizes. However, when we group them into mold sizes, we still have to put in consideration of the specialism of the blocks, and also when we're loading the blocks onto the auto trimmer, we still have to do like a visual QC to ensure the consistency of the embedding, the tissue orientation, and also to make sure the surface exposure for diagnostic evaluation. So challenges and solutions. When we first approached the machine, there were quite a few challenges actually. So to start with, to be validating uncertainty. So the trimming is not usually a method that is kind of validated when you kind of have a new microtome. So like we were unclear to where to establish the protocols. So that's why we kind of seek out help with XLab to kind of see how we can group the protocols together. So we decided to group them with roll sizes and then assess them according to the specialism and also like with visual QC. And then dense tissue. So these are like uteruses and also like colon resections, like hard tissue types required protocol adjustments. So that kind of reflects onto the phasing and the roughing of the protocols when I will talk a bit more later on. So the solution of this would be to like refine the protocol speed and the strokes and the depth setting, which I'm going to show a bit more in detail later on. And also another challenge would be excess wax on the side of the blocks. For instance, like sometimes when a block hasn't been like skirted properly, there will be some wax on the block. And we found that the machine is quite sensitive in accordance to like excess wax. So we kind of implemented like a systematic block cleaning procedure to ensure that the machine won't reject any blocks. And last would be our biggest challenge, because in Cambridge University Hospital at the moment, we are still doing all our embedding manually. So there is a lot of variability between embedders and the quality of the blocks. So to tackle this, I've introduced some embedding like refinement to like training to align with the auto trimmer trimming. So to kind of like improve and also to engage with the staff to emphasize how now standardization of the quality and also the blocks and embedding benefits the auto trimming and automation in the long run. So I have produced a graph, a histogram. So these are the blocks that I have loaded onto the auto trimmer and the observation value on the auto trimmer as well. So the x-axis would be the full phase value and the y-axis would be the frequency. So as you can see, before embedding training, our range for full phase varies a lot. As you can see here, between the standard deviation, the gap in between is very large and the median is 740. So to determine a kind of trim depth for one protocol can be quite challenging without implementation of any further embedding training. So if I go on to the next slide. So this is after we've been introduced embedding training to kind of refine the techniques of embedding and emphasize on how embedding would affect the auto trimmer. And then as you can see, the orange is the after embedding training and the blue is the before embedding training. So as you can see that just by clearly, the standard deviation between the before and after has shrunk a lot. So after embedding training, the standard deviation is so much tighter compared to before embedding. And then the median has dropped down to 660 compared to before where it was 740. So with the newly improved graph, determining a average trim depth would be a lot easier and a lot more accurate to represent the types of blocks in the future, which loads onto the auto trimmer. So optimizing the tissue processing protocol. I think this would be the kind of easiest step compared to the previous. So this is to kind of optimize for hard tissues, like dense tissues, that kind of increase the chance of like trimming artifacts. So so to kind of assess the performance, it will be through visual assessment of the blocks to see whether there's any artifacts, and then the slides would be stained to see when any like microscopic like artifacts will be there. And then if these are observed, then we will modify the roughing, the phasing, and the polishing values on the kind of protocols to preserve the section's quality. So at the moment, we are at the stage of where we are fine-tuning the facing and polishing process. Okay, cool. So dial back a little bit, so to determine the trim depth, we loaded the block onto the auto trimmer and just set the protocol as 800. So to determine the full face, we will stand by the machine and just let the machine trim. And then when we think that, oh, it's full face, and we just stop the machine. And then as you can see, this is when the stopping happens between potentially roughing or facing parts. So there's a lot of trimming artifacts on the block. This is a uterus, so it's very prone to trimming artifacts. So the next phase would be the trial protocol. And this is when we decided to set the trimming depth to 600, and then kept the roughing and the facing and the polishing the same. But this time, the block will be able to go through each process. So roughing for 25 cuts, facing for 10 cuts, and then polishing 0. But as you can see, there's a dramatic difference between the blocks already. And then to kind of fine-tuning the protocol, I have changed the facing down to 1 and then increased the polishing to 2. So as you can see, the result is so much even better. The artifacts are so much more reduced. So these are some stain sections that has been trimmed and has been cut on the AS as well. And we stained them, and I took a print screen on the digital pathology of the scanners. The sections are pretty promising. And this is a uterus. In terms of trimming artifact, that's not practically none. And this is a skin specimen as well. Again, there's literally no trimming artifacts to it. So in Cambridge, we are striving for automation excellence. However, the first step would be raising automation awareness. So since automation is such a new concept in histopathology, so to kind of increase the awareness and the benefits of automation and workflow, we need to kind of bring in staff training, staff engagement, and also with quality integration. For instance, enhancing quality control for automation doesn't start before embedding. It starts from sampling to the embedding technique. So number 2 and 3 kind of goes hand in hand. And then kind of number 4 would be the learning curve. Since it's such a new process, we are always learning from adaptation to training strategies and open to suggestions. So future outlook. So our next step would be to continue to kind of to optimize the protocol to different tissues and mold types while maintaining standardization benefits through intensive testing and validation cycles. And then to build on that, to kind of build on consistent trimming, we can optimize it, digital workflow to enhance automation in diagnostic pathology. And last would be to kind of build a supportive framework to training and validation in the future. So thank you.
Thank you, Paolo. Thank you. I think you have a point here in terms of validation and why it's really important. But I also want to say that automations like these, as you're saying, it's an in-between step.
Yeah.
It's something we have not seen before,
yeah.
and we have not tried to validate instruments like this before. With the AS, it's quite easy. You can take a section from this, and you can take a section manually, and you can compare it.
Yeah.
Here you have one go. And this is where that the validation process is going to be different from side to side.
Mm-hmm.
However, of course, it is really important that the one that comes out here could be translatable to what we're seeing here, because artifacts here is translatable to what,
Yes.
and of course, what you're measuring. What I want to say is that the important thing is, of course, also to understand the matrix in which you're implementing your units. So to do a workflow assessment, talking about what could be some of the challenging aspect of bringing automation in, because we know that automation thrives on uniformity.
Yeah.
And that is clearly at Cambridge, that the more uniform you can have your blocks in terms of, cleanness and the depth, the more easy it will be to implement instruments like this.
Just by like implementing that little final step, like embedding training, just to how that would affect the autochroma really kind of benefits our like lab validation. And to kind of just see just a little bit, and it makes a massive difference.
It does. And I think what we don't know, or we don't think about, is that when you're doing a manual setting, you don't have to, you are accommodating to the situation. These devices are not, accommodating to everything. So thing has to be on point before. And this is the challenge. So I wanna, Zahrah?
Sarah, thank you. I just want to just add quickly as well. I think this journey of automation, before we've decided to automate anything, I think it is really important to be looking at our own processes, because whatever we are trying to implement here is not a like-for-like comparison. So what we've almost observed in terms of the automation is forcing us to rethink about how we are doing work, what is the level of the quality of the work as well. So what we would have accepted to be acceptable in a diagnostic process manually, the automation is really forcing us to really step out of our comfort zone and actually really leveling up the quality of work. So as Paolo has been discussing with the AT192, a lot of their variable has come from the embedding. However, it's really highlighted to us in terms of how do you further improve your embedding, because you're relying on manual embedding. How do you standardize that even further? Because different people will have different, there will be some variation which you can't escape, but from a manual process, you're still making that decision making. But what you're doing at the moment is how do you standardize that enough so that the automation helps you to do less decisions essentially. And I think this is why it's taken us slightly longer to get this validated, because we want to get it right, but I think also to improve the whole end-to-end process, which then impacts on the digital reporting and digital pathology as well.
And surely, and the improvements you're doing are not only benefiting automation, it will benefit the manual work as well. So thank you, Paolo. Thank you for your insights. I just want a little introduction to Nadia, because Nadia and Odense has done the validation quite differently. And this might goes to show that the more automation you're bringing into the lab, some of these validation steps might be a more smooth sailing than others. So it's with great pleasure that she's just gonna be mic'd up now. That's why we're waiting a little. But it's with great pleasure that I am welcoming Nadia Nielsen from Odense.
Thank you very much. Thank you for having me. Yes, I hope everyone can see. Yes, I have a presentation with me from Odense about implementing of the AT192, where in an experienced automated laboratory, as we think we are, because we have a lot of automation over the last couple of years. My name, as Amalia said, and thank you, is Nadia Nielsen, and I'm the lead laboratory technologist in Odense for the histology lab. So just short what I will be talking about today. It's a short introduction of our lab, so you can see how big we are and you can compare it to yourself. Then a little bit of the journey of our automation of our laboratory, and then a lot about the AT, of course, the implementation. Then a lot of numbers. I know it can be quite difficult sometimes to understand all the numbers and statistics, but try to hang in there. And then I have taken a little bit of the benefits I think you can get with the AT. And then, of course, if there is any questions. So just a slide about how big our laboratory is. We are an university hospital in the southern Denmark. So we are the biggest hospital in our region. So quite a big department with a lot of medical staff and, of course, a lot of medical laboratory technologists. In the histology part where I work, we are around 50 technologists in total. So how big is our production? Because I think it's very important to the numbers I will have later on in the presentation on how much we are actually producing in our lab. And of course, the latest numbers is the most important, but you can see it has been quite steady over the last 6 years here. So the numbers of blocks isn't increasing here with us. And I think it's because we are trying to look into how can we save blocks and take the right tissue out for inspection with the pathologist. So around 230,000 blocks per year is what we are counting on having. So I will take you through our journey of automation, and I will promise you it will not take very long. But I think it's important to understand where we are today and how we can embrace automation and how quickly we are embracing the automation here in our laboratory. So some of the first, of course, we started with printers for cassettes, and that before 2012. But the first thing I have taken with me today is the automated embedding, because that started in around 2012, 13, and with the Sakuras A120. We had one at start, and then today we have two who is embedding around 70% of all of our blocks in the histology department. So that's quite a big load of our blocks, and not as many as other places, but in Denmark, I think we in general has a lot of automation with embedding. After this, there came the first installation of the AS410M. We got it in 2018, and we're very excited. We got a little bit where we should find out if could it save staff or anything like that, because that's what everyone is thinking when you are starting the automation. But for us, it was not about saving staff. It was about getting the quality of the section higher than we already had when we are doing manually sectioning. So that was the reason why we bought the first one. Today, we own 3 AS410M, who is doing a lot of our sectioning. As you can see, almost 70% of our total in blocks are sectioned on the AS today. One of the instruments is actually sectioning all of our controls for the immunohistochemistry. So we have made a change for that when we got the third one. Then there is the scanner, or DIPA as we call it, the digital pathology. We started with archiving scanners. We had that around the same time as we started automated embedding. When just for archiving in 2020, we started to do digital pathology as we know it today. So today we are fully digital in all the histology samples that we have. So today we are scanning around 1,600 slides every day, where the pathologist is doing all the diagnostics by screen. Then the next part, because when you have a lot of glass to handle, and what should we do about it after the scanning, we were introducing an archive robot in 21. It was to help us with handle all of the glass, because we didn't know what to do with it, because we have always thrown our glasses out after 3 weeks. Don't be shocked, but we do that in Odense. I know it could shock some people, but all the hours we were doing it manually for saving the blocks in that archive and that archive and that archive, it took too much time for a technologist who could be sectioning blocks. So we got a archiving robot instead, who can receive and disposal of our slides for us. And in 25, around 6 months ago, we got a second robot because we have too many slides. So no manually moving of slides in our laboratory today, is all done by robot. So for the AT, we got it in February in 25. We have it only for borrow from the X Lab, so we're very, very excited for that, but hope to purchase it. But we have had it for almost 6 months, and it was to see if we can get the benefits for trimming for blocks for the AS410M. for about 6 months, we have trimmed about half of all our blocks on the AT instrument. What the future brings, I don't know. I think a lot of more robots is on the way. Maybe someone will replace me, I don't know. So, implementing of the AT. I'll just say AT from now because that's way easier. As I just said, we started it in February this year. We had 2 days of training with the support from AXLab. We had a lot of blocks made before that. I think I remember that we were embedding around 500 to 600 blocks, both automated and manually, that we could just cut through and throw out afterwards. So we were testing the different blocks, the different specimens, the different types of block sizes and depth in those 2 days of training at the instrument. We actually only used 1 day of testing the different protocols in it. The reason I think we could do it in just 1 day is that many of our blocks are automated, embedded. So we already know how deep we have to go to the block before we have the surface that we want before going to the AS system. Before we had the AT, we were trimming on Zahrah's, what it's called, the Zahrah's automated auto section, thank you, where you also can use some protocols where we have already tested different protocols. So we were just taking those protocols into the AT. So we didn't use a lot of time on testing different protocols. And then 3 days, we were ready to go. And we did go with patient samples after that. A little bit about protocols. As Amalia said earlier, there were 8 different protocols. We are using every 8 protocols that the instrument has. Sometimes we are using a 9 also because it has a 9 protocol. We are using it for different size blocks and for different depths. Our protocols are from 600 to 130 microns. So it's not a large scale, but it's very important because you have so many different kind of tissues and the depth of the blocks. Every protocol in our way of setting it up is under a minute. So for us, I think it's very quick. We took time beforehand on how long a technologist would do it, where they are also cleaning the blocks, and that will be around 30 to 40 seconds. So it's not a lot more. Then you have the additional cut. And at first, of course, we were very cautious on how deep could we go in the block. But when you are getting used to it and you have the experience, we are not using very much of the additional cuts anymore because we trust the depth that we have set to the blocks. So there is where we are now. And then a lot of numbers, and I will try to take you through it. But it's the numbers from the 6 months that we have had the instrument. So it's how many blocks for each month that the AT has trimmed for us. As you can see, it varies a lot. And of course, there is reasons behind it. In February, it was the month that we got it. So it's both the testing blocks and actually patient's blocks. So everything that we had that we could get onto the instrument were going onto the AT. So that's why it's the most high number in February. Then March, April, we have some startup issues. We, with help from AXLab, we got and Japan actually, we got the technologist over to help us settle with some of the difficulties that we have. So that's the reason why we didn't trim so many blocks in that couple of months. And then again in May, we were using it in routines for all the blocks that we had. And then July, the summer came and not so many blocks. You can also see for the errors in the start, there was a lot of errors, and that's one of the reasons we have to get some help again from AXLab to figure out why did we have so many errors, and we were changing some of the setups for our protocols. And you can see now where it's more routine in the laboratory, there is a fewer errors on the systems, and I don't think you will ever get a 0 there, but hopefully, but we will live with that kind of numbers for errors. And the more runs you are doing, the more errors you will get. A little bit more numbers, because again, a little bit about how big we are and why it's important to us. For the 6 months that I have just shown you, there is how many number of blocks that we have been sectioning on the AS and the numbers that we have been trimming on the AT. So it's around 52-53% that have been trimmed, automated instead of manual for the AS 410M. I have taken the time also in that statistic because it says a little bit about what you can remove from manual working out in the laboratory. It will never be one-on-one that I could say, okay, that many hours I will remove 2 or 3 technologists. But it is that time where my technologists can do more specialized work out in the laboratory. So yeah, I'm very happy for the automation, as you can hear here. But as more standardized sections that I got, the more easier it is to go for digital pathologies, and it's more easy for the pathologist to do the right diagnosis. Then for the right, I think for you, I have built some numbers for the business case that we have done about this instrument. So it's the numbers of blocks that are trimmed and the number of blocks that are sectioned on the AS. And you can see the percentage of blocks are increasing over the months. And it's to tell my bosses I have to have the system, because the more blocks I can get trimmed, automated, the more I can save out in the laboratory by staff. And of course, we all have time issues about staff and to cover up vacation or sickness or maternal leave, or otherwise just get enough employees. So that is the numbers that we have built our business case up around. Yeah. Then I will talk a little bit in our workflow and how we do it in our laboratory with the AT. And I will not say this is the golden standard to do it, but it's the way that we have done it for the past 6 months that we have it. So we are starting in the morning, because we work from 7 in the morning to around 15 in the afternoon. So we are waiting for the blocks to come from the automated embedding. So that has to be embedded before we can use the AT. So already there we are losing some time where an instrument could be running. It is about an hour before the first is ready, and then we will start almost throw it in the system, because we just want it to be trimmed as fast as possible. We start with 1 tray or the first blocks that comes out of the automated embedding instrument, and put it over for the first one. Over the day, because we have more and more blocks, because the automated embedding is quicker than the AT, we can put more and more trays on it. It will be around 3 or 4 trays at a time, sometimes more. So it's keep on running all the time. And the main purpose is, of course, just getting blocks ready for the AS. In our laboratory, we can have 1 AT for around 2 AS in that kind of workflow. As I said, we have 3 AS systems. So when we are using all 3 AS systems, the AT can keep up with feeding them all 3. So there we have a technologist besides trimming manually on our auto section. Yes. We are not doing any night run, but you could do it, and maybe you should do it, because then we won't have enough blocks for the AS. We want, of course, like everyone else, our blocks to be sectioned as soon as possible. And right now we have room for all our blocks on our AS systems. So if we had to leave some for a night run in the AT system, then the AS will wouldn't be running overnight. And that's our main goal, that the AS is running overnight or even better before we even are going home for the day. So that's the reason why we are not doing night runs. And for all the time that we have it, depends on the number of blocks, but it has almost been finished before we go home every day. And then, just to be a little bit ignorant, I have tried to take a workflow with how you could do it, but I don't say you have to do it, but in my head, it's the way you should do it to get the most out of the AT system. The best part, if you want that system to run as much as possible, will be if you have blocks waiting from the day before. So as soon as you start it up, this is very quickly, you could already put blocks in it. So as soon as an employee is meeting in the morning, they could put block in for trimming. I will say 3 to 4 trays at every run will be the best, maybe 5, but if you have that kind of numbers of trays in every run, it will be enough for feeding 2 AS systems, in my experience. Again, I thought a little bit about it before, but a night run. I think a night run will be awesome because then you have blocks that are ready for the AS system when you are meeting in the morning, but it requires that you have enough blocks for that, or a backlog or something like that. And for now, we are actually, for the first time in 20 years, don't have enough blocks for that. So we are very excited for that. But I would think that will be the best workflow around to get 2 automated systems running as much as possible. And if you have to build a business case, something like that, it will typically be something that your bosses or manager will ask about how long can it run. And the good thing about instruments is it can run 24 hours at a day. So, and with that workflow, of course, I will think you should not use any technologist for trimming. So it will only be the AT for trimming. Again, it will depend on the number of blocks you have, how many AS systems, how many technologist is trimming for manually sectioning, but it's various. And with the idea of that this workflow that I explained, I would think if I had to implement it in our laboratory, it will give a minor delay of the section blocks than it do today, because I could see if I wanted systems to run all the time, then the blocks have to wait for going onto the system, either the AT or the AS. But today in my laboratory, we can use our technologies because we are enough employees for the moment. So the blocks are being sectioned quicker by letting out to the technologist or by trimming by the technologist. So you have to have that delay. But if you have a lot of blocks just waiting for trimming, this could be a workflow for that. A little bit about the benefits I think the system has. Of course, it can trim for the AS directly. As Amelia said, they are compatible with each other, the same trays for the same instruments and all that. You can save some technologists. And I don't want to stand here and say, buy this and you will save technologists. I don't say that because I haven't done it. But I can see that I have, in our experience, I have in my when I have to plan the day for the technologist, I have taken 1.5 technologists out for trimming for other tasks because I have the AT. So you will save some employment for that. And I will say you should put in from some other tasks instead of taking off the paycheck. The same preparation as for the AS one, you don't have to do anything else to the blocks than you have to do for the AS. As has been said in some of the other presentations, this is very important to clean the blocks. We already knew that because it's also important for the AS system, so we are already doing that. Now we are just doing the before the trimming, where before we were doing the after the trimming. Also, I think the trimming is better for the blocks than what we did before the AT. It's more sensitive, it's more not as rough for the blocks, so you don't have that artifacts in the blocks. When we are doing manual trimming, it's very rough because we just have to do it quick and with a lot of microns. But in the system, you can do, as Amelia said, just rough and then facing and polish to the end. So it's better for the blocks, and in the end, you will get a better result on the sectioning from the AS. And then it only use blade as consumables, where a lot of other instruments, automations, are using different kind of consumables, slides, tape, whatever. I'm mentioning all that from the AS right now, but also inserts for cassettes or something like that. This is only using blades, so it's very easy and it's low maintenance. So it took only a technologist a half day to learn what to clean, what to be prepared of, how to navigate on the screen and all that. So it's very, very low maintenance. So five good benefits, I would think. And maybe I have talked a little quick, but that's all for me.
Thank you, Nadia.
Of course.
That was great to hear. Would you please join us as well, Paolo? So coming to your point, I think, of course, that when we are talking about one-to-one, automation and staff, it will never be like a one-to-one. But again, the parallel workflow is not able to take the work from the lab technicians. It's made to support and have that supporting backbone, so that exactly what you're saying, that you can use your staff to do other important tasks that where automation is not at the moment. So you're completely right with that. Have you been, surprised by her method in terms of validation? Now it's quite different.
It's very different.
Yeah,
yes,
very.
So, yeah. Because I think because you're automated and us, we are still manual. So I think the approach will be slightly different in that sense.
Yeah, I think so too. And I think it's because we are very secure on the automated at all of our instruments. So as you also said, how will you validate a microtome, a normal microtome? You're not doing that. So if you have to validate manually trimming, you have to validate the technologist, because it's the technologist who has to see it. And I think our approach is that we have seen it in the same way. So we are not validating the instrument, because of course we were checking with the test blocks that it didn't ruin any blocks or something, but we are validating that can we set the right protocol to the right block, because that's actually a technologist works.
Exactly.
So if you can compare like that, it's the way we have seen it.
That's the quality eye, ensuring that you don't get artifacts. So that is how you are tailoring it. Yeah,
exactly.
Yeah, but it was quite interesting to hear that you're being quite honest about some of your lab techs might have a rough approach to how they did trimming before and how that has actually helped.
Yeah. We are always seeking to see more, how can we improve the quality of our section? Because, as you said, we are always looking in the patient first. And it's also our motto, the patient first. So how can we secure that we get the best sections to the pathologist so they can make the right diagnosis? And I think a lot of laboratory has experienced if there is a very, if there is, busy, thank you. My English is going out here. If there is very busy, then the employments have a way of just going even more quickly about the approach that they would do if you didn't work as busy. So, and when you have done that for a long time, if you have been busy for a long time, that will be your golden standard, even though it's not the right way to do it. But it's
the default in you.
You're just doing it like you used to do it.
Yeah, exactly. And you can recognize this as well, maybe at Cambridge.
Yeah, I think
the fast trimming. Table shaking.
A bit of everything.
A bit of everything. Yeah, one of the things you didn't mention that we are seeing in other markets is actually the alignment when you're trimming. So when you are really quick and fast, and if you're not taking care of the maintenance of your trimming microtome, it's going to have slight of a tilt, where then it's going to cause alignment issues for the AS. And we have just seen with other countries that it has actually helped to the point where they don't have that many misalignments based on uniformity from this system.
Also a good benefit.
Yeah, it is. It actually is. Great. I think you are burning in with your questions, so we are now going to do the questioning, the Q&A session. So my dear colleague Mehdi, she will She will read it now. The first question.
Okay. What would happen if there were staples in the specimens with facing and then sectioning?
Yeah. Should I answer? Would you answer? I
have tried it, so I can try
Okay.
to answer it. We have not a lot of staples, but we have staples in some of our samples. And at first, actually, it was some of the problems that we have. Again, I will be really transparent about it. It will ruin the block. But then we got the help from Axlab and from Japan, and they were making the more sensor about how much pressure there is to the block, and if the instrument can feel some more pressure than they should, they will stop. Is it right?
So it is. There is a cut force limit. So if it exceeds that limit, it will retrieve that block, change the blade, and continue with the next. And this is, of course, an approach because we know that some pathologists are not the best, or it could be lab techs,
Yes.
not getting rid of max seeds, or it could be the staples that are going into the system. So yes, but I think you also had a different approach, or maybe it was Liverpool having like a sensor detecting metal. Isn't that at Cambridge you are doing
I think
that?
we started, we did that before, and then it worked for a bit, and then
and then you
we just kind of
then you got good at it, right? So now you don't need it. That is how you're angling it. That's also.
And also kind of goes back into embedding as well. When you kind of do see some staples, sometimes you kind of just pick it out, and then that's when the kind of embedding training comes into as well, to reinforce that, potentially you might see some staples or the sutures left into the tissue, that you just take that out, and then that can be potentially encounter that issue.
That's, of course, a benefit you have when you're operating with manually embedding, because you don't have the chance.
See it. No,
once it's in the net, it's in the net. You don't have a second chance.
So we will first see it when we are trimming.
Yeah. So maybe it's like reensuring that pathologists and lab techs are not doing it, but it will stop if it overexceed the limitations. Yeah. Next question, please.
Following up on that, how does the trimmer deal with chunked blocks of tissue popping out of the block during trimming?
Have you any?
No.
experience?
A little bit, but again, it was in the start of our journey with the AT, because then we got the improvement on the instrument. We have seen a few blocks where there has tissue being hopped out of the block, but not after we did the improvement of the blocks. So I think it's not happening anymore, but I don't know for sure. And again, the most part will again go through the embedding, like you said, because what kind of tissue is it manually embedded? Is it automated? But it also has some.
And of course, I feel the importance here is also to try to accommodate. If we know we have really dense tissue, that we would try to accommodate the speed, and of course the micron count, so we don't always necessarily have these ripping out tendency that we know with some tissues they're more prone to do. Do we have another question?
We have many nice questions.
Okay.
Are all tissue types validated for the AT?
I guess you're referring to Nadia, since
for us, yes, it is. We are running everything that we are putting onto the AS system. So everything that we have validated on the AS system is also validated on the AT. And it's from skin biopsies to colon biopsies to large tissues as uterus, mamma, etc. We have a large scale of tissue types. So yes, for us it is.
There must be some sort of trust in the device putting biopsies on.
Yes, very much, and that's why we have the protocol with not very much, but we have seen it that it's not taking very much. And again, as you showed in the start, we can, if it's in our department, it isn't standing where we are working, but if the device was standing where you're working, you can see on the screen and stop it before it goes too deep in the block.
Exactly.
So, but a lot of trust in the protocols that you have done. So, as many blocks as you can testing on it will give you that trust. And we put a lot of blocks through it when we got it at first.
Yeah, we do have installed in another site that actually said, I'd rather want to have my staff looking at the screen, just pointing to when it stopped, and then just continuing by having them sitting in a microtome. That's a different perspective of utilizing automation. Yeah.
How is the trimming of really small tissue? GI biopsy, prostate core biopsy.
Okay.
We don't have any core biopsies on it because it don't go on the AS, so we haven't tried that, but GI biopsy is okay. You just have to set the protocol to the right terms, I would say. And again, it comes to the embedding part. Everything is from the start. You have to do it right from the start. So when we got the AT, we made the transfer over from manual embedding for our gastrobiopsies to automated embedding, because then they were lying in the same layer, and we know exactly when they are in these nets from Sakura, how deep we have to go before the biopsy comes out for facing. So we did that transition because of the AT.
Because of the AT, yes. And do you have not experience with?
No, we
biopsies?
haven't experienced with biopsy yet. We are not testing that at the moment.
No.
We're still doing the mold sizes
and then
moving on.
Yeah, but we do have sites that want to expand, and of course expanding will be also what can we throw on the AS, and that will be biopsy next. Cores could be really difficult because the nature of a core is often not even. So this is going to be really challenging. How do you set a average depth on a core?
Just to come back, just because it was a clarifying question.
Okay.
Are you running the core biopsy?
We are not running the core biopsy.
Okay.
For the random biopsy.
Yeah.
What if the tissue is not on the same plane? Can the auto section adjust angles?
So
the block,
I guess what she's referring to is if there is an AI solution that can check where it needs to flip the block in terms of further trimming, and that is not the case. It will align in terms of the surface of the block and not the orientation of the tissue. So in the event that tissue is not aligned, you will have to add additional trimming. Or you would have to re-embed. And this is why, of course, uniformity is the best. So if you can ensure that you have it embedded in level, you're not risking of having additional cut, because additional cut will prolong the process time to a point where it's starting to not to be so efficient. Do you have any comments to that?
No, I think I think you covered it pretty well. Yeah.
Great.
When using an automated embedder, how does the AT192 handle the plastic inlays?
Because of the big vacuum in it, its handle is very good. In the 6 months that we have had it at our laboratory, we have seen that it got stuck in the vacuum 2 times. And it's sometimes because of the protocol, if you have set the roughing too high, so the plastic is too thick, and then the way that it's suction, if it goes on cross, you can say, so it's got stuck. But we haven't had any problems with it otherwise, and it's very easy to clean afterwards. So it doesn't do anything bad for the samples.
And I think in that relation, we also changed the block count. How many blocks do you actually do per blade?
Yeah, exactly.
Because we know that when you are in a chilled environment like the ACE and the AT, that the plastic will harden. And this can, of course, make the blade dull faster than when we do it manually. So there are pros and cons to all, you can say, embedding platform. I think uniformity here, and this is, of course, where you don't have the nets, so you can actually meet your tissue quicker than you can do from the Sakura.
Is the AT suitable with small block molds, the 1 type 1 centimeters?
So 1313 or 15 by 15, yes, that is doable. That is doable.
In our department, we use the Darko tracking system, where each tissue block is assigned with a unique QR code. During the microtomy stage, the system generates a label that includes another QR code to maintain traceability for the slide. Are the machines compatible with this type of system?
So currently, this is not incorporated with the limbs. So it has a barcode, and of course, eventually, potentially, we would like it to be implemented with the limbs. But currently, it's not. And the first step will be that it will send files back to the limbs saying that this has been trimmed by the AT. But for this unit, it's not integrated. This, however, is integrated. And you can do a lot with, you can say, barcode FBI numbers within a barcode. How have you handled the fact that this is not integrated?
In In start, we didn't think much about it because manual trimming isn't integrated either in our laboratory. It's only manual sectioning that is integrated in the LIS system. But with those kind of errors that we saw in the start, it would be nice if it would go to, and again, with the traceability you have to do today, it's the thing that we want the most. If we can see where everything is going in time in the laboratory, so right from embedding to section trimming, again, coloring, if stains are not traceability in our laboratory for the ATE, but for immunostains, we can see on which.
What about
platforms.
in Cambridge?
We're still quite early on in the validation, so we haven't thought about it yet. But now, with the introduced barcode scanner, we can potentially like link it back to the limbs to say it's been trimmed on the AT, and then it's like a tracking system for us to make sure that it's been gone onto the AT, and then we can load it onto the AS as well.
And of course, you also have the ID of the block in the bottom of your images. So in that case, you could link the images.
Nadia, there is a specific question in your presentation. You spoke to errors during the validation. Around 10 now. So what are the errors mentioned when using the AT? Was diagnostic tissue lost? Was the blocks cut through, etc., or was it just a block being chunked and required rebedding?
Okay, the errors that I was referring to were when the system were going in some kind of error. So it's errors that the system has detected by itself. So it could be a technical error, or the blocks wouldn't place right on the trace, or something like that. So that is the number of errors that I was mentioning that. But as I said early on, we had some difficulties, and errors was that we lost a couple of blocks where tissue were lost in the AT. Yeah.
And that was why you were accompanied by Japan.
Exactly. And we haven't had it since.
No.
So yeah. But it can also be errors like the blade wouldn't change or something like that. So it's
doors open.
Doors open, something like that.
Then we have a question regarding overnight runs.
Yeah.
Do you normally have overnight runs in these machines? And if yes, are they then connected to a on-call system if an error occurs?
We have tried the overnight run, and it's not connected to anything, so it's a little disappointing coming in the morning and see there is an error if there was. In general, as you can see now, we don't have a lot of errors, so we are trusting in there isn't any error, and if there is, we just have to start all over again.
Yeah, and you're not at the point where you are doing any validation work over the night, right?
No, not yet.
No.
Not at the moment.
No.
But potentially eventually. Yeah.
Yeah, because the interesting thing is actually what I have calculated is if you're utilizing this device, you will, as you're alluding to in your presentation, you will start off by using the system, the AS, fast in the day, and that could potentially give you an increase in your workflow.
Exactly.
So have this work at night, and we do have sites that are using this at night, mainly because of a backlog, as you're alluding to, but are doing it for the night run. So when they meet in, they have 2 times 4, which will be 2 full AS runs.
But could it be set up to alarm systems?
So it could,
because it
could. If it's connected to the Wi-Fi, you could actually have it on an email, on a phone, and then you can set it. What type of notification do I like? Do I want it notification if there is an alarm, when the operation starts, stops, whenever that is? Yeah, that could be potential. Yeah.
What about continuously loading and unloading?
I won't answer that, I think.
Because you're not doing continuous
Yeah, we are doing, but not what I'm calling continuously loading.
No.
Because you can load, you can stop and take something out when the machine is still running, and then the trace that you have already set will still be continuous after you have taken the first 2 trays out. And we are doing that by daily. But in the perfect world, it will be nice when I'm taking the first 2 trays out, and if the last 4 places is still available, I can put 2 trays under
Yeah.
that while it's still running, and you can do that.
And that you will get the facing settings, so
Exactly,
you can select
yeah.
even more. Or if we are really talking about the future, what could be good is if you in your barcode will have the protocol,
Yes.
so you don't have, so you can actually swap one tray with another, and then it will just continue. But yeah, continuously in the sense that you cannot feed for one tray and then place another.
Are there any types of tissue that are difficult to trim and should be processed manually instead of using the automated trimming function?
Very small biopsies, I would say.
Alluded to the core biopsies will be. And of course, we can always discuss bone material that hasn't been, decalcified. But again, this will also be a struggle manually. So I think it will transpire.
Yeah, and again, it comes to the start of the workflow. If you can see when you get the blocks from embedding, it's not if you have 2 specimens in the blocks, if they are not placed in evenly, don't put it on, because then one of the specimens will be right, and the other one will not
be exhausted, and then and maybe for you it will be if you can see the orientation is not on point. Then of course you will have
just kind of reinforcing what I kind of talked about in my presentation as well. Is more like before loading onto the AS, you still have to do that visual QC as if you will be doing manually trimming. Because when you are manually trimming, if you see a block is not leveled, you wouldn't trim that. So when you put it on the AT, you would be doing the same. And also with any like calcified blocks as well, we are embedding manually. So when you are struggling to embed that calcified block, then you would know that, oh, it might not be suitable for the auto trimmer. Then you might have to put that for manual trimming.
For small tissue samples, is there any section criteria to determine if they are too small for automatic trimming and automatic sectioning?
I think it comes down to the experienced technologists to see how deep it is when they are embedded, and the knowledge that you have for the different tissues that you have in your laboratory, because you can set the settings to very low. So if you have a lot of biopsies who is really, really small, you just have to do a protocol that is not going very deep in the block. So I think it comes down to the knowledge for the technologist to make that decision.
And maybe this is going to shock somebody, but there is often this that when we are taking a biopsy, we are embedding it flat.
Yes.
And if we are changing that perception of embedding, that if we are raising it up, you're actually earning a bit more in your height. So maybe this could actually feed into more usage of the unit, because then there'll be more comfortably with the height then. Yeah. More questions?
Oh yeah.
Oh yeah.
We have it hard.
Does laser recognition, does it recognize the depth of the target tissue beneath the paraffin and its sides, or how does it actually?
So this device is trimming by fixed values. There's no laser to detect anything or no AI solution. So it's a fixed set of microns that you are applying to individual blocks. And this is why manually embedding or orientation of the tissue is so important.
We have touched upon this one, but I will say it anyways. How does the AT handle bone?
Okay, who will be in?
I don't think we have a lot of bone, but we will try to feed it on it and see how it goes. And if it has been decalcified right, it will be just fine. So again, a lot of the things when we are talking automation is it starts where it all starts in the sectioning out with the pathologist of your tissue. Select the right tissue, select the right protocols for tissue. If you have bones, how long should it be, the calcification, and so on.
Okay.
Yeah.
So the pre-analytics.
Yeah. So we are not worried about putting bones on the system.
What about you? Have you experienced with bone?
Not necessarily bones, but more like sometimes very hard tissues. And with the new system update, if it exceeds that kind of initial trim, when the blade touches the block, when it go over that limit, then it won't cut that block. So it would just kind of reject it and put it back onto the block holder.
Exactly. Yeah.
So that kind of prevents any further trimming or like block popping out or chunking or anything.
Yeah.
So it just kind of rejects that block.
For safety and
safety
reasons, yeah. Yeah.
In our lab, we process tissues from lab animals, and in some tissues we have to get specific regions on the slide. For instance, parathyroid combined with thyroid gland. How does the machine know that it has trimmed far enough and or not trimmed past the parathyroid?
Yeah. So
I know.
I think this is a good question, because a lot of potential customer thinks that there is an AI solution to where it can detect where to stop with the point of interest. And this is not the case. Again, it trims by a fixed value of what you set in the protocol. Now, we hope in the future, and I cannot guarantee you anything, so don't quote me for this, but we hope in the future that we are going to find a more AI relative solution for the trimming. So maybe we could potentially find, based on contrast, based on what the point of interest, better than just setting an average. Question?
Yeah. Is the data contained in the barcode on the as produced slide customizable? An example, case number, suffix, block number, slide number.
So I think we're referring to the AS now. So yes, we can customize and tailor how the print layout should be based on a CSV file. So that's the communication platform, you can say, that the AS is doing. This one is not integrated.
We print the blocks from our limbs. But if the machine is not compatible to the limbs, how can I include the protocol for the AT on the barcode of the block?
Could you just rephrase it just a bit?
They print the block from the limbs.
Yeah.
But I guess it's actually because it is compatible to the limb system that I do not know how to answer it. But the question is, can the user include the protocol for the AT on the barcode?
No, not currently. We are hoping in the future. Maybe also you can talk into that, Nadia. We're doing the same with the AS.
Yes.
So we're doing specific sectioning parameters based on a staining or a tissue type that, of course, is linked in the barcode. And that's why it knows which parameter to take. And we hope in the future that that will be translatable for the AT as well.
So we have one more clarifying question. Can GI biopsies be trimmed at the AT?
In our laboratory, they can. Safe.
And you will test it.
Yeah. We'll test it.
Yeah.
Yeah. Which other companies in the market we consider as main competitors? What makes AT different?
So I think the main competitor would be, your microtomes, or as you are alluding to, the previous Sakura auto section. That would be one of the most compatible competition units out there. The thing that makes this really different is, of course, you have your steady environment. You don't have that in a manual setting. The ambient temperature is calling to it and is affecting the block. And of course, the fact that this one is treating the block most the same way as this one would do. So you have less variations going from one system to another. And this is what we have been seeing in practice before introducing this to the market. Then the variables coming from a microtome, regular microtome, to this one, it has a significant impact on how the performance could be. Do you have anything to add?
No, I think that's right. In exactly the point where that the two systems are compatible, because as you said, the auto section that we are using trimming for manually, it's about if if you are trimming a little bit off, or it will be a problem in the AS. And you are, with this solution, you are getting on that.
And actually, if we take like a staff environment perspective, this is going to save the cuts and the injuries there might be. I do remember autosection, and it could lead on to potential. Yeah. And you're doing normal microtomy, right?
Yeah.
Normal trimming.
And when we are talking into that and the employer environment, all sectioning is hard for the body. And it's something that, as I said, it was the reason why we bought the first AS. It's for quality, but also we had a lot of employees where we saw there were shoulder issues and neck issues. And that is typical, something you see when you have done microtomy over a long time.
Yeah, and the block handling, right? Because it's really like
putting in and out. It's hard for the fingers.
Yeah.
How much time do staff need to learn how to operate the AS and AT combination after they are introduced into the lab?
What would you say?
I think it varies, and it varies around the workflow that you have in the lab. We are saying we are using 1 week intensely with one employee for the AS system alone. So after 1 week, they will use it and be a mainly daily user of the instrument. And after we got the AT system, it only took a half day to introduce and to learn the cleaning, and then of course, we use a lot of time to explain to our employees how our workflow is in our laboratory, because our workflow is a lot about get as many blocks through as possible. So the main thing they have to think about when they have learned the instruments and they are trusted in the instrument is how should I plan my day? So, okay, I have put 3 trays on the AT. When is this finished? Okay, I have to get that to be at the same time as the AS is finished. So that is what we are using a lot of our training time with new employees on when they're coming into a combined system.
Do you have the answer for Cambridge?
So because we haven't got the machine for too long, so for us, when I first learned the machine and how to use it, it's actually quite straightforward, the interface itself, and it's just, put it in simple terms, pressing buttons in a way. But in terms of like technologists and also support workers, just more like confirming and refining like what logs can be loaded onto the machine, and just kind of having that kind of quality control beforehand, as well as what you would do for like manual trimming, to be honest. So the interface itself is pretty straightforward.
And I think both systems combined, we will look in an installation and training session that will cover more than a week. So we will be there. We might not have back-to-back trainings a week and more, but we will be there on site in order to understand, as you're alluding to the workflow and how we can try to tailor a workflow and of course parameters.
Are protocols assigned to entire trays, or is it per block?
So maybe you're not able to see it here, but you can actually, sorry, Nadia, you can actually tailor on a tray level. So the colorings here is actually indicating that I'm using, in this case, 3 different protocols. Yeah.
We have other.
Okay.
Are the instrument used in non-clinical part of pharmaceutical industry in GLP plus labs?
So this one is not, but we do have research lab that has purchased GAs and then with good experience. We actually have Novo Nordisk in Denmark, and then we have Agilent, former Darko company, who's actually having this instrument as well. We do have Genentech as well in the US, part of the Roche group. They also have one purchased and doing sectioning for them.
The final question
Yeah.
is, sorry, just to clarify, VAS is compatible with tracking systems or just with the limbs?
With the limbs.
I think we are right on time.
Perfect.
And I think I remembered all the
Good.
questions. Please give me a second to look through.
Okay.
Yeah.
Okay, I want to thank you all for tuning in, and I want you to keep aware and your eyes open. There might be another webinar soon, so keep your eyes open for that. I want to all to give a big thanks to Paolo Ho and Nadia Nielsen. Thank you so much for participating and enlightening us in this. Sorry. And of course, not to forget Zahrah. She's behind the screen, but thank you, Zahrah, once again for participating in this webinar. It was great. And once again, I just want to say thank you for our cooperation and how we are executing. So thank you and stay tuned. Bye.
Bye.